David, you've taught me that the summer is really the time of both CMS, the Centers for Medicare and Medicaid Services, issuing proposed rules, and the community, both the kidney community and the physician community, in our case, responding to those rules. And that's kind of how you spend your time at the beach or at the pool, as opposed to reading novels like the rest of the normal population. And unfortunately, I think you've infected Lauren with this desire to also read rules by the pool. Kind of rhymes, doesn't it? Just sort of curious as to if you want to focus there today.
Yeah, we would love to focus there. And Lauren, thank you so much for joining me in this cult of reading summer rules, because it is truly a cult, but we all kind of know each other and we're kind of happy to be in the same cult together.
Well, I'll spend my summer reading, the latest novel by Tana French, and you guys will go through proposed rules, and we'll have a good time.
I love Town of French. Does she
Yeah.
have a new one out?
She does. It's interesting. It's a continuation of the last one, and she's definitely moving in a different direction. And we can maybe we'll do a book club podcast in the future.
Okay. Okay.
I don't know if you didn't work with former ASM president Sharon Anderson, but she is my literary guide. So whenever I'm looking for a good book, I ask for her opinion, and she points me in a direction. And she's never steered me wrong. So I just want to give her a shout out because she has incredible taste when it comes to fiction and nonfiction. So why don't we start with the Medicare end-stage renal disease programs, prospective payment systems, the quality incentive program. So the acronym there is the ESRD PPS QIP. Can you just start with sort of what that all means, and then just walk us through kind of what happens each year? I mean, I want to kind of start at the beginning and then move into the substance of both what's been proposed, what you think the community's reaction is going to be, et cetera.
Well, as all of our listeners know, the whole ESRD, the kidney failure benefit within, and we call it ESRD, although a lot of people call it ESKD these days, but that is statutorily the name ESRD, and that's what CMS uses because that is what is in statute. So we're not trying to keep up with the times. We're just like dealing with the reality of what it is. So as everyone knows, the whole program for dialysis and for people with kidney failure, it's been bundled on both the side of the dialysis provider and also a monthly capitated payment also for the physician and nephrologist. And that's over in the physician fee schedule, which we're going to get to a few minutes later, because that also has come out this summer. And within the ESRD program, the bundle is in the prospective payment system, the PPS. And that's where all the payments are in calculated for how ESRD facilities are paid. And then in the QIP is the quality incentive program. And that's where all of the quality metrics and the things that are, been determined by various groups to help improve the quality and outcomes for patients is housed. And so there's a lot of tension between those two different things. But let's start with the PPS. The problem we're going to hear from dialysis providers, and rightfully so, is that this base pay rate is not really designed to keep them afloat. It's designed to cover just Medicare while private insurers pay other rates. But the catch is Medicare is so pervasive, it's very hard to keep some of these numbers of, keep everything working at the same time. So there'll be a whole lot of discussion around what those base rates are. There's going to be a lot of discussion this year around the facility wage index for ESRD facilities, and that is commonly a big particular prediction. And wage indexes are adjusted in certain areas by different factors in an area. There's also a lot of discussion in this one about low volume payment adjustment. So those are kind of like some of the main things and the overall market basket. So if we go much further, I think we'll just like bore everyone to tears. But let's just say that it's a pretty intricate, complicated situation that we will be looking at. But I think ASN, while supporting making really strong payments there, we're going to focus a little bit more on the QIP because that's really for outcomes of patients.
So before we move to the QIP, and I do want to circle back about market basket in a second, Lauren, is there anything you want to add to David's overview? Because I think it was helpful to understand we're dealing with both payment and quality. We're dealing with both dialysis facilities and health professionals, particularly nephrologists.
Yeah, so I think David did a really good job with the overview, but I guess if there's some numbers in there and help, maybe that will be a segue into our next point. So this year's proposed rate for the ESRD PPS QIP base rate is 273.30, which technically is a $2.18 increase from like payment year 2024. However, like David mentioned, it still is not enough to keep dialysis facilities running as well as they would like.
Yeah.
And,
And it doesn't count for those missed evaluations that in the last couple of years we've asked them to go back and correct that they have not.
and just so I'm clear too, we're talking calendar year, not federal fiscal year. So this would go into effect January 1 of 2025.
That's correct.
And so just again, from a timeline perspective, the proposed rule kind of comes out at the beginning of summer. Then our responses, the community's responses are usually due sort of right around Labor Day, and then usually around Kidney Week, between sort of Kidney Week and Thanksgiving. CMS issues a final rule where they sort of consider all the input from the community. Then they go into effect, 6 weeks later, January 1.
That's correct. It's solid money to bet that it'll either take place a day or so before Kidney Week or during Kidney Week or the day after. It's that tightly aligned.
All right,
So
well, I'll hold you to that. Before we move on to the QUIP, which I know we want to spend some time on, can you give us just the 30-second, what is market basket and why is it so important?
well, Market Basket is used by CMS in more than just the ESRD program. It's also used in the hospital-based programs. And it does have it has several things in it. And off the top of my head, I can't quote everything there, each one to you, but it does deal with things like wage indexes. It does deal with costs. It does deal with various things that affect how a facility can run. And they put that together and they call it their, productivity adjusted market basket. And that's, and much more beyond that, it gets really hairy really fast, and a lot of economists spend a lot of time breaking it down. But it is something that is commonly used in Medicare to make adjustments for facility payments, not just ESRD.
Yeah, and I think when we talk later this summer to Zach Cribbs about everything that's happening on the appropriation side, when we get into funding for medical research, the similar adjuster is called Bird Pie. And please don't ask
Yeah,
say what the acronym is, but I think the point is, which is really important, is that a lot of individual variables are combined, and so little adjustments in one of those variables can make a huge difference. And so it's not a great situation in the sense of from a policymaking perspective, because there's just so much variability. I guess the analogy I would use, and tell me if you think this is right, is part of the reason why there's such a challenge about understanding what if we're under inflation is depending on what you measure. If you're measuring housing costs, that's very different than say food costs, et cetera. And so there's just a lot of how things get calculated tends to drive public policy positively or negatively.
that's correct. That is very much correct.
So
If you don't mind, I'd like to bridge here. Is that okay?
yeah, all right. Can't wait to hear your bridge.
Okay, so the bridge is, I'm going to tell you something it's a hybrid. It comes out of the payment part, but it's really taking us over to the QIP part, to the quality part. And that is something that we were very excited for and had worked very hard for many years, along with a lot of other people in the kidney community. And that is this year, CMS has agreed to make site of care neutral for people with AKI, with acute kidney injury. And what's important for that is if you go in and let's say you have other procedures, you go in with other issues, might be heart surgery or something, and you develop AKI while in the hospital, and then the nephrologist gets brought in at that point. The catch had been that CMS would not allow Medicare, would not allow you to discharge that patient to home. You had to be discharged to an ESRD facility. And there's a lot of concern about whether or not that's the right way in which to do this, because also there's evidence that peritoneal dialysis, which is primarily done at home, is also likely to really kind of maintain some level of kidney function greater than hemodialysis. I'm not the nephrologist here, so I may have gotten that a little bit wrong. I'm quoting our people, so but the catch is that they have now said, okay, we are going to allow you, we're going to allow this to be a decision between the doctor, nephrologist, and the patient. and then make a determination as to whether or not that person wants to be trained. So that, in other words, you could be started on PD and trained in the hospital and then go home and not go. And sometimes people have been started on PD, and then they have to be prepared to be switched over to hemodialysis, which was happening a lot in COVID. This is still something that needs to be done on a case-by-case basis. What is good for that patient? What is good? What does the nephrologist think? But it is an opportunity to really free that decision-making up from the agency's hands to the physician and the patient's hands. So we were very excited to see and hear about that.
So it hadn't occurred to me until this moment, but with the recent Supreme Court case on Chevron and sort of the difference between what's in statute and what's interpreted by the agencies, do you feel like this fits within statute, or do you think there potentially could be a Chevron challenge to this?
There is more in statute in a lot of the kidney programs than there is in some of the other spaces. So, you would have to dig down. There's some things in the conditions for coverage and guidance that relate back to some of these issues. And so this is one of those that really basically, I'm not sure it would be a clear one to be affected by the Chevron decision. And I know Lauren, as our producer, wants to do a Chevron episode, and we will do a Chevron episode because it's a big question. But I will say honestly, because people will be hearing about it, there is something that they did that we wish they had not done, and everyone's going to be dealing with it. They did make an adjustment. They claim that the pay is going to be exactly what ESRD facilities are furnished to pay for patients with AKI. But the catch is that they are doing a training adjustment for that. So in some ways, the reality is that for the ones who go home, that would be an $8.50 adjustment down. And so that's when it's going to be worked out. A lot of members of the kidney community are asking MedPAC, and MedPAC is the Medicare political group it's not political, it's a nonpartisan group that advises Congress and about various policies, about whether or not it's possible to take that AKI out of the neutral adjustment. It may be even just for the first couple years until uptake comes. They did decide that they could do that on the pediatric level. So if they were able to do that on the pediatric level, we're hoping we can get them to do that on the adult level as well.
Okay. So just to kind of provide a summary of where we are in our conversation. So we started talking about the payment side of the Medicare ESRD program proposed rules. We then moved into the AKI news, which is mostly good, although there is this hugely concerning aspect of it, which is kind of a bridge because it's both a payment issue and a quality issue. We want to talk a bit about the quality side, the QIP side of the proposed rule.
Yes.
And to a second proposed rule. So just for people storing at home, we're talking about two different proposed rules, but the first one has kind of section A, which is the payment piece, section B, which is the quality piece. I know it's not that simple, but it's a way just to kind of keep track of everything we're talking about.
No, you're pretty much on spot. That's pretty much the way it works. So going to just kind of go through a couple things that I think will pique our readers' interest. ASN has been advocating for disaggregation of the KT over V between, because of PD adequacy as opposed to HD adequacy. So that is a really big issue. They have made a proposal that would disaggregate PD from the hemo, and they've done it in 4 components. But they still did not follow completely what we had encouraged them to do from the guidelines from the International Society for Peritoneal Dialysis. And I think there's going to be some interest in trying to take what they've done and refine it even further. I know that our group, the groups of our committees that work on ASN on these issues, they're very interested in doing this. So they're also going to do this. They're going to remove the NHSN bloodstream infection clinical measure, the BSI, from the QIP because it's topped out. However, there's always a however, they are still going to have some of the events being reported by dialysis facilities. And I know that dialysis providers who are going to basically say, wait a minute, you're continuing to have us report this, it's rather large. amount of work to be done, and that's that kind of counterproductive. So that's something that's going to be really discussed in detail. Orals in the bundle, phosphate binders in the bundle. Yes, we knew that that was going to be there because it was set to be in there for 2025. There is legislation moving through, and when Zach joins us in a couple of weeks, he can go over that. There is legislation moving through Congress that may delay that for another 1 to 2 years. Okay, but like I said, that's not happened just yet, but it is moving at this moment. So there is also a section on, as the ETC model, the mandatory model, begins to wind down, as it approaches its end, what should they be doing to really continue to push for increased home dialysis use post that payment model? And I think there's a lot of things there to think about, and we'll be very excited to add comments for that and to think about that with them.
So, David, before we move to the physician fee schedule, the second set of proposed regulations, I just wanted to pause and see if Lauren had anything to add in terms of the QIP side of the proposed rule on the Medicare ESRD program.
No, I think David did a great job, and now we're looking forward to hearing about the physician fee schedule.
So the other sort of news is that usually around the 4th of July, the Centers for Medicare and Medicaid Services drop a proposed rule for physician payment. And again, this is something that people like David and Lauren spend their summers reading by the pool as opposed to reading novels like normal people. I know that you haven't had as much time with this proposed rule. I'm just sort of curious, Lauren, you've had a little bit more time to go into depth on the proposed rule for the physician fee schedule. What jumps out at you?
Yeah, so I guess we could start with the overall physician fee schedule. So unfortunately, this year, average payment rates under the physician fee schedule are proposed to be reduced by 2.93% in calendar year 2025. Nephrology fared fairly well compared to other specialties. For nephrology, the total non-facility / facility allowed charges is going to be around $1,500 this year. Where nephrology kind of fared well was with the combined impact of the RVUs, and nephrology actually saw a 1% increase there. Overall, payments are still down from last year. I believe the total non-facility / facility allowed last year was about $1,800, so 15 is still a decrease, but still, again, not as bad as other specialties. I wish I had the number specifically, but overall, pretty okay.
Yeah, I mean, I think the challenge is that the way physician payment has been positioned in the federal government because of budget neutrality. We're constantly in the situation of just trying to get to break even, and so over time it becomes significantly impacted in terms of what we're paying physicians. And I know there's a lot of frustration in the community, especially when you look at, say, the profits being generated as a result of, say, Medicare Advantage and some of the insurers or something. So there's clearly a bit of an upside down system here, and at some point that's going to break. And again, that's a topic for another day, because I don't see this as being sustainable. A, because physicians are being pitted against each other by specialty, and B, because there aren't any real meaningful increases, and it's getting harder and harder for particularly physicians in smaller private practice to survive financially. David,
I think that's also, and we'll be with Zach Cribbs in a couple of weeks to talk about where we're in the legislative process. That is very much on their minds of Capitol Hill about taking the physician fee schedule and giving some authority to CMS to use inflationary adjustments, which currently it's within a very tight cap that doesn't. But I'm going to switch over to something exciting and very good news for patients that we have been working on for some years now, and that is we've been working on including the kidney community has been working on providing dental coverage for people with ESRD and also for candidates for kidney transplant or anyone for solid organ transplant. The organ transplant piece had been picked up by CMS. That's been done. That's fantastic. In the last year, particularly at the end of 2023, National Kidney Foundation and ASN took another run at it, and also asked that certain ESRD codes be placed into this category as well. So they took us up on that suggestion, And CMS is now going to be providing dental services associated with dialysis treatment for patients with ESRD or with kidney failure. And there is some other things that are being looked at also within medicine, not just that, but that is something that it's gone from not only being a candidate for transplant, but also being someone who's being treated with dialysis. So I think this is really good, exciting news for patients. And Dr. Larry Coffey, a longtime dentist and advocate for patients, we're going to shout out to him, who's worked with ASN for years to work on these issues, and thank him for all the good work he's done for people all across medicine who need dental care.
Well, thanks, David. Lauren, I want to give you the last word on the physician fee schedule. And is there anything else you want to highlight before we close?
Yeah, just a quick note. We're still going through this process, but there's also going to be 4 new measures that are added to the nephrology specialty set. So keep an eye out. ASN comments on them every year. So we'll go through those and have comments on that soon.
That's great. Well, thank you, Lauren and David. I know this is how you spend your summer, and we'll have an episode in the future. We'll do the summer book club, but enjoy working through the proposed rules, and also to thank all of the ASN members, particularly in the ASN Quality Committee, who spend an inordinate amount of time and resources working through these with us and with other members of the community.
And I'll throw in the Policy and Advocacy Committee, the PAC, because they pick up when CMS can only go so far, they pick it up and take it to Congress, and so it's got to be both hands have got to be working on this.
All right. Well, thank you both.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.